Hey guys.
Hi.
Looks like there's about 2 more minutes, so we'll wait till people show up here before I start. But so, did you guys do work on those math problems I gave you?
Yeah, some of them.
Any issues?
Uh-uh.
Okay. Hopefully those will just be easy questions for you. No problem. So, how do you guys feel about this stuff for this coming test? Do you feel like it's not as bad, or do you feel like you're still unsure about certain things, or what?
I'm unsure, to be honest.
Okay.
Me too.
I'm just worried, I think, so I'm overthinking everything.
Okay. Well, generally, people typically do not too bad on this test, so I don't think it seems that too difficult or anything. So we'll try and get through a lot of stuff tonight. Hopefully, that'll make you feel better. So, are any of you guys done with clinical yet?
Yeah, I'm done with both.
That's good. That's gotta feel nice.
Yeah, definitely. It's a lot less work now.
Yeah. Hopefully, the rest of the term will just be smooth sailing. All right. Well, it looks like it's 6:30 now, so I'll just go ahead and get started. I'm recording this so people who aren't here can hear it. So I just wanted to just kind of recap some of the stuff we went over real quick and just make sure you feel okay with the different topics. So, as far as the vascular stuff goes, so remember you need to know the difference between what peripheral artery disease is and peripheral venous disease is. So, two different things. So, remember peripheral artery disease, you're thinking, oh, intermittent claudication. So remember, intermittent claudication just means that if I have peripheral artery disease, when I get up and move around and I start walking and doing any type of exercise, I start having pain and I'm having discomfort, right? So that's like one of the number one complications or like signs and symptoms, I guess you could say, of peripheral artery disease. Something else that would be like really um, probably something that you should know about peripheral artery disease is that if that extremity has it, you're going to have uneven peripheral pulses then. Like if I'm looking at my foot on this side and then I'm looking at it on this side and I'm comparing, I'm going to have, maybe no pulse over here and then I'll have a +2 over here, or maybe it'll be a +1 here and a +2 here. So there's going to be a difference in your pulses. Um, Peripheral artery disease also has to do with blood flow. So think that when you're thinking peripheral artery disease. So, in other words, if I have a blockage somewhere that's causing me to not have good blood flow, then what happens to that extremity?
Not gonna have any blood flow into it, obviously, right?
Well, yeah, so you don't have blood flow there. So, what's going to happen to that extremity?
It's gonna die.
Yeah. So you can get like gangrene really easily with peripheral artery disease. So anytime you would see that in a question, you're always going to think, hey, PAD, peripheral artery disease. Okay. Then when you think peripheral venous disease, you think of those 3 things we talked about. So it could be like, hey, I have a DVT or a thrombosis, or I have varicose veins, or I have peripheral venous insufficiency. So, in other words, what causes peripheral venous disease would be, um, hey, there is a blockage, so like a thrombus or something, or there's damage to the vessel itself, or those valves inside the vein aren't working anymore. They're just letting blood like go, both ways instead of the way that it's supposed to go. So you get all of this collection of blood down in your lower extremities that doesn't go back and return to the heart like it's supposed to. So that's what causes all that edema. So you have lots of edema in your lower extremities, and you're going to get those venous stasis ulcers, and you can get that brown discoloration and the whole 9 yards. So that's peripheral venous disease. So if I asked you a question about what is something you could do, like intervention wise, to help with or to help prevent peripheral venous disease problems, especially after surgery, what would you say?
Compression stockings?
Okay, that could be one thing. What else?
Early ambulation.
Yes, that's huge, right? Because if we're thinking that maybe this person might end up with a clot or something, then if we get them up and move them around, what's that do to your blood flow? It helps move your blood around, so it's not just sitting in that one spot all the time, right? So that's good. So think like that, like prevention type things. So other things. So think about varicose veins for a minute. What are some things that you could do to help with varicose veins? Because think about who's at risk for those. Remember, it's like pregnant people, they're going to be at risk. People who stand or sit for long periods of time are going to be at risk. Um, those types of things. So what would you do to help prevent getting varicose veins? Sometimes you can't, hey, I was pregnant and I got mine because I was pregnant. I can't prevent that. But if it's because I'm not moving around very much, what can I do about that?
Move around.
Yeah, right? So if you make a point, like if you know that you stand in one position like for so long because that's what you do at work, if you make a point of moving around like every hour, like going for a short walk or doing something, that will move all that blood around even more so you're not going to have that issue, you know? So that's kind of something to think about too. Let me think what else. And then like with this vascular stuff, I would also just think about, some of the treatment that we do for it. So, um, like heparin drips and that type of stuff. I would think, a little bit more about that stuff too for this test. So you might need to, know some of that. So I don't think I asked a ton of questions about that. Let me look at it real quick. Oh, what's cigarette smoking do to your vessels?
Constricts them.
Yeah. So that's another thing you need to know. So I'm just counting how many of these I have here. There's probably 15 from the vascular stuff. And it's all pretty straightforward type questions. Now, there's one that has to do with, where's it at? There's one that has to do with venous thromboembolism. So it talks about what preventative actions should you recommend to prevent a venous thromboembolism. So what kinds of things would we say to people that we would say to do so they don't get that? Sure, when we're in the hospital, yeah, we give heparin, we do the SCD, devices that pump up and down on their legs and that type of thing. But what could you do as someone who isn't in the hospital to help prevent getting this?
Ambulation and not smoking.
Okay, not smoking, definitely. Regular exercise would be something, right? So make sure you're moving around a lot. And then what's another thing that you would be concerned about that might make you more at risk for that? Believe it or not, your weight. So if you're overweight, that's going to cause you to be more at risk here. So if they could do some weight loss, that would be helpful, that would help prevent this from happening, hopefully, in the future. Okay, so like again, 15 questions on that stuff. That's like the first part of the test. Then the second part, let me see how many of these there are. Okay, so there's probably like 10 questions on the hypertension stuff. Okay, so that's not as heavy. So when we talked about all of the hypertension stuff, most of that's pretty easy and you should know all of that as it is. Like tell me something that you know about beta blockers. If you had to teach someone about taking a beta blocker, what would be something important to tell them?
Is it the cough?
No, that has nothing to do with beta blockers. You're thinking of ACE inhibitors.
That it could drop your BP, so you want to move slowly, like when you stand up.
Yes, that's a great thing to teach someone, right? So, yeah, when you think beta blockers, you're thinking, okay, I'm taking this for my blood pressure, so I know it can drop it. And yes, you can have postural hypertension or hypotension from that, excuse me. So, your pressure could drop and you could pass out real easily. So, you definitely want to move slowly. Other things to think about with beta blockers. Remember, we said if you're diabetic and you're on a beta blocker, it can mask your symptoms of hypoglycemia. So if you, as a diabetic, already can tell when you're getting low, being on a beta blocker, you're not going to be able to tell anymore. It's going to just kind of sneak up on you. So that's something that your provider needs to know so they can watch out for that stuff. Another thing about beta blockers is that, we have hold rates usually. So if your heart rate is less than 60, we're going to hold it. And sometimes you might have a hold rate from your physician about the blood pressure as well. So, like, you could see a physician say if your systolic is less than 100, hold it. So it just depends physician to physician on that. But the heart rate will always be, less than 60. Another thing was if you have like a respiratory history, if you have asthma or COPD or something along those lines, and you're on the beta blocker, it can cause you to have bronchospasms. So that would be another thing to remember. Okay, so tell me the difference between someone who's in hypertensive emergency and someone who is just having a hypertensive um, episode that, like, maybe they come into the hospital for this hypertensive episode, but what's the difference? Remember, we were talking about hypertensive urgency and emergency. What's the difference between the two?
Is the hypertensive emergency, do they have to do with like organ damage or something?
Yes. Yeah, so if someone doesn't have any signs of organ damage, but they still have a high blood pressure, we're still going to treat their pressure and we're still worried about it. But the person who actually has some organ damage going along with their high blood pressure, they're a little bit more severe. So we treat them slightly differently. So the person with hypertensive urgency, yes, they have a high blood pressure. Their, systolic's probably over 180 and their diastolic is probably over 100 for sure. Now, we would still bring them in, we would still treat them, but we're probably going to give them just medications that are going to help bring their pressure down that could just be by mouth medications, right? Now, if this was someone who was in hypertensive emergency, where we have this organ damage going on and we have those high blood pressures, then we want to bring that down quickly. So this person is going to be in the ICU. They're going to be heart monitored. We're going to watch them super close because we're going to give them nitroprusside. And remember, we said nitroprusside is not the same thing as nitro, two different medications. So nitroprusside has a really short half-life. So the idea is if you give that to someone, it's going to help bring their pressure down within like minutes. It's really quick. You don't want to give this for a long period of time. So you would just hopefully get their pressure down and then take them off of it and put them on something else. Because remember when we talked about it, we said that nitroprusside, when it metabolizes down, it ends up as being like cyanide. So it's very toxic to the body to have that. So just kind of keep in mind the differences between the two and what you do to treat it. So they're a little teeny bit different. So if you had someone that had hypertension and it was uncontrolled for a long period of time, what are they at risk for? What kinds of like long-term complications?
Heart failure?
Maybe. You guys can't think of anything else?
This is probably not right. Kidney damage.
Yeah, kidney damage for sure. Anything else? Aren't we worried about like things like stroke? When you have a really high pressure, what can it do to your eyes? Can it do things to your vision?
Yeah.
Yeah. So there's questions on here that talk like that. So you need to kind of, make sure you focus in on things that could happen if it's not treated. Okay, so in that whole PowerPoint that I did on that, we talked a little bit about like the proper way to take a blood pressure. And then right after that, it talked about things that can affect a blood pressure. So we said like if you got up and did some exercise and walked down the hall and then someone went to take your blood pressure, it would affect it. It wouldn't be the same as it would have been if you would have taken it when they were just sitting there. What other things can affect your blood pressure?
Caffeine.
Caffeine, definitely.
Medications.
Yeah, medications for sure. What else?
Smoking.
Smoking, for sure. And then we even talked about like white coat syndrome, sometimes when you go into the physician's office and you get all nervous, stuff like that can affect it as well. So there is something like that on here. And then remember we talked about the difference between primary and secondary hypertension. What's the difference between those?
Secondary has like a certain cause.
Okay. Give me an example of a secondary cause of a hypertension.
Like a narrowing of renal arteries or something like that. Constriction. Am I on the wrong one?
So secondary, we said, does have a different cause, right? So it means that like maybe you have a tumor, like remember we talked about that pheochromocytoma? That's a tumor that you could get that causes you to have high blood pressure. So if they took the tumor out, you wouldn't have it anymore. So that's like your only cause for it. And then, we talked about having high blood pressure when you're pregnant, that could be the cause of this. So once you have the baby, you don't have that anymore. So you see what I'm saying? So secondary, it has an actual cause, and it's only, because of that they have the hypertension. So primary doesn't have like an actual, hey, this is what caused it. So sure, they may have lifestyle things that point you towards, oh yeah, this probably did contribute to their high blood pressure, but there isn't anything that's like, oh yes, this is my actual cause. Okay. So what are some of the things that we say kind of contribute to high blood pressure?
Obesity.
Definitely. What about the way that we eat? Like what in particular about how we eat would cause you to have high blood pressure?
Salt.
The salt, right? So high sodium intake. And then even like lots of things that are real high in saturated fats, that could be something. Oh, let's see. Oh, and also don't forget that primary hypertension and essential hypertension are one and the same. It's just two different words talking about the same thing. All right, and then on the one PowerPoint that we talked about the high blood pressure stuff, I had the one thing where it showed the new recommendations for blood pressure control. And remember, we said they did away with the pre-hypertension, and now we have elevated stage 1, stage 2. So there are a couple questions where you'll have to figure out which stage they're probably in. So just make sure you take a look at that. All right, and then the second half of the test is all just renal. So, of course, we talked about acute kidney injury. That was a big portion of what we talked about. So, how do you know if someone has an acute kidney injury? What's pointing you towards that?
Their lab work, the BUN and creatinine.
Okay. What else?
A decreased GFR.
Okay. But it's not just the labs. What else is happening?
Injury.
Oliguria.
Yeah, it's the urine output. That's what I'm waiting for someone to say. So you don't just look at the labs. You obviously have something else happening that's making you think there's a urine issue. So usually it's a decrease in urine output. Usually that's one of the first things that you'll see. And then you go, oh, okay, maybe I need to look at some labs. And then you look at the labs and see all that other stuff, right? So acute kidney injury definitely will have a decrease in urine output and then also those differences with your labs. So remember, this is something that is reversible if you catch it quick enough. However, if someone stays in it for too long, it can end up as a chronic kidney problem, right? Okay, so did we talk about, I can't remember if we did or not. We talked about kidney biopsy before, didn't we? Or did we? Yes, no?
Personally, don't remember talking about it, but
I don't either.
Okay, well, obviously it's in your chapter, so you can look at that. But sometimes if someone has something going on with their kidneys and you're not quite sure exactly what it is, you may want to do other testing. And one of the things they could do is a kidney biopsy. If they do a kidney biopsy, that's going to tell them for sure if this kidney has like a lot of disease to it, or if it's just acute kidney injury, or if it's something more severe. So that's kind of, what we're talking about with that. If someone has urine retention, what kinds of signs and symptoms would you see?
Edema.
Okay. Like if someone has urinary retention, the typical person who has this, if you were doing a physical assessment, you'd be able to see their bladder is actually distended, as you're feeling it and as you're looking at it. And then some things that they probably would say to you that would make you think that they had this would be, oh, I feel like when I go, I can't get it all out. Like I feel like I still have more to go, but it just won't come out. All right. And then, so you remember when we talked about like older adult men who they have prostate issues, you know how that the prostate surrounds that urethra. So as it gets bigger and enlarged, it can cut the flow of urine off, right? So what do you think that could cause if you had urinary retention because you had an enlarged prostate? What could be a complication that could happen from that?
Can't get all the urine out and then a low urine stream.
Okay. What else could happen though?
It backs up into the kidneys.
And then what?
Continence.
Well, maybe, but what I'm looking for is urinary tract infection. So if you can't get all your urine out and it's just sitting there stagnant, what's going to happen? It's going to get infected, right? Does that make sense?
Yeah.
All right. So when we talked about kidney stones, we were it's kind of a short little talk about kidney stones, but we said that you could have a stone pretty much anywhere in your urinary tract. It can move. And depending on where it's at, your pain might feel a little different. So the place where it feels the worst is going to be in your ureter. So this is where you'll have that stabbing pain and like flank pain and lower abdominal pain and stuff. It feels like more stabbing and severe compared to where it would feel in other places. All right, if you have a cystoscopy, Remember, a cystoscopy is just where they have like a camera on this probe and they actually stick it up into your urethra and it goes and looks around in your bladder, right? So this cystoscopy, if you have this done, what can be some things that you might see afterwards with this patient? What should you tell them that they might see happen?
Blood in the urine.
Yeah, because just from the trauma of that being up there, it's not that they're gonna have like a ton or anything. They'll probably just have a little bit. But yeah, so that's not uncommon to see that after a cystoscopy. So that's something you would want to reassure someone about. Let's see. Okay, what's acute glomerulonephritis? So remember, this is something that I want you to associate with strep. So we said a lot of times people will have an episode of strep, or maybe they had strep throat or something and they were treated, but then a couple of weeks later, they start getting these symptoms. And what are the symptoms that are associated with this?
Weight gain, low grade fever, lethargy,
What else?
high blood pressure,
Okay. What's your urine look like?
Concentrated?
I'm sorry, I didn't hear that. What was that?
Is it concentrated?
Kind of, but it's going to look like hematuria, right? It's going to be like a brownish color, you know? So with acute glomerulonephritis, you're going to see it look like that. So when we talked about nephrotic syndrome, we said nephrotic syndrome, you have increased permeability of these big proteins. So you get lots of protein in your urine with that one. And with that one, your urine would look like frothy, like. So with this, you have more hematuria with this.
What did you say was the protein in the urine?
That's with nephrotic syndrome. Okay, so I'm just trying to look through this to see what else I want to ask you guys. All right, so when we talked about like chronic kidney disease, we said that when you're at this point, there's 5 different stages. Stage 1, you're doing pretty darn good still, but once you get to stage 5, that's where you have to be on dialysis. And it also, looks at your glomerular filtration rate. So as your kidneys get worse, they're not going to be able to filter all of that stuff out of your body like they did before. So that's when they need more help, and that's when you would go on to dialysis. So how often are you supposed to do dialysis?
3 days a week.
Yeah, usually it's 3 days a week. They usually do like every other day or something. So the other things we talked about when we talked about this were all the different things that the kidney does. And so because you have this problem with your kidney now where it's so damaged, it's not working as well as it did. So some of the functions that it normally would do, it can't anymore. So that's why like you would see a high blood pressure with someone with chronic kidney disease, because normally, the kidney helps, control your blood pressure, and now it can't because it's damaged. We also talked about red blood cell production and how you may have to give them like erythropoietin to help, make some red blood cells because now they can't. So think of some of those things when you're looking at the test as well, because that hopefully will help you answer some of this stuff. Do you remember when we talked about another one of the functions of the kidney had to do with oh, I'm drawing a blank here. So anyway, one of the things, scratch what I just said. Let me just say it this way because I can't seem to say it correctly. So one of the things that you see with chronic kidney disease is that this person always has problems with their electrolytes, right? So one of the problems is that they have too much phosphorus. And what did we say happens when you have too much phosphorus? Think back to adult one. Remember, calcium and phosphorus kind of go together. So if you have too much phosphorus, what happens to your calcium?
It's decreased.
It's decreased, right? So there's a certain medication that we tend to give chronic kidney disease patients to help bind with that phosphorus to get it out of their body so that they can use some of the calcium that they do have. So what is that?
Is it Foslo?
Yeah, and sometimes you'll see it called a few different things. Calcium acetate is another name for it. There's a few different names for it. But generally, when are you supposed to take this?
Before every meal and snack.
Yes. So basically every time you eat, you're supposed to be taking it, right? So anyway, there's a question that has to do with that medication. So make sure you're looking at that. With dialysis, what do we hook someone up to do dialysis? They have to have like some kind of port of some sort to be hooked up to, right?
Are you talking about a fistula?
Yes. So tell me what you know about a fistula.
Isn't it like where they put like a vein and an artery together so they're stronger?
Yes. And so when they get hooked up to dialysis, then they, one of the sites would like take all of the, bad stuff out of their body, feeds it through the machine to clean it. And then the other site, the new clean blood would come back into the body, right? So you need to know that you can't take a blood pressure in that arm. You can't draw blood in that arm. You have to be really careful with that arm, right? Because we don't want to mess with this fistula and cause it to not work. There's only so many sites you can have a fistula, so we want to baby it and make sure it's okay. So how do you check and make sure that is working properly?
Thanks for-
Listen. Hmm.
What's that?
Go ahead, Jen.
You listen for breweries.
Yeah, so you check the thrill and the bruit. So the bruit is the sound that you hear when you put your stethoscope over top of it, right? So you're supposed to hear like this whooshing sound of the blood going through there. And then what's the thrill?
The feel.
Yeah, so you're going to feel that rushing blood going through there. So if you don't hear it very well or you don't feel it very well, you're having an issue with your fistula. So that's how you can kind of tell. All right. Let me think what else here. Oh, so we did mention nephrotic syndrome a few minutes ago, but if we were talking specifically about that, what would be some other things you would see, like signs and symptoms with nephrotic syndrome? We said that their urine would look frothy because of the protein, the increased protein that's being lost in their urine. But what else would you see? So you're going to see edema, right? You remember learning about that? You can see facial edema a lot of times around their eyes. You see it in other places too, but that's like a little bit more prominent there sometimes. So they're going to have like a lot of excess fluid in their body because of this. So, just remember that. That's a big thing to know. What is the disorder called that is genetic, that where you get all of those cysts all over your kidney? What's that called?
Polycystic.
Polycystic kidney disease. Can you do anything for that? So there really is no treatment for that. So if someone gets that, they're going to end up probably going into chronic kidney failure, and they'll end up, maybe needing to, have a kidney transplant or go on to dialysis eventually. So with these polycystic kidney disease, you get these cysts that develop all over the kidney, and they can be multiple sizes, and they're fluid-filled cysts. And the thing is, if you went in and you tried to drain one or take one out, more would just pop back up in their place. So it's like you can't get rid of them. So obviously, if someone was having trouble with one, it was causing problems, you could go in there and drain it or whatever temporarily to help with that. But yeah, there really is no cure for it. So the biggest concern with polycystic kidney disease is we want to try to keep their kidneys as healthy as we can for as long as we can. So this means we want to keep really tight blood pressure control to make sure that's going okay. So that's your biggest concern with that. And then we did kind of touch a little bit on incontinence when we had, I think Maggie did a presentation on that. And you have that in your ATI book and stuff. So just review like the different types of incontinence, because there's something on here on that. There's a little bit about like UTIs and stuff. But that's, for the most part, that's most of everything right there. I didn't tell you everything, but that's most of it. So I did make a Kahoot, so we can go through that real quick. If I can get it pulled up here. Let's see. Okay, here we go. Okay, which is a cause of glomerulonephritis? So remember I told you to associate this with strep. So acute post-streptococcal. Okay, what's the characteristic of nephrotic syndrome? So remember we said massive proteinuria. So they have increased permeability of their membranes inside their kidneys. So they're losing all of this protein in their urine. So that's a big thing with nephrotic syndrome. The hematuria goes more with glomerulonephritis. Okay, medical management of polycystic kidney disease may include what? Okay, so this is the blood pressure control because really there's nothing else you can do for it. Okay, a common cause of kidney disease is it's both high blood pressure and diabetes. Which kidney disease is known to be inherited? Yeah, so polycystic kidney disease. It's the only thing that we talked about that has a genetic component to it like that. What is a cause of intrarenal kidney injury? It's the nephrotoxic medications. So remember, intrarenal injury is injury to the kidney itself. So with these medications, that would definitely do it. And typically it's like aminoglycosides and, a couple other things, but aminoglycosides are a big one. Okay, prerenal kidney injury is caused by what? So this is decreased circulating blood volume. Boy, one of you answered this. Come on. So remember, with pre-renal, usually it's like a decreased blood flow or something. So like shock or a burn or something along those lines. So definitely decreased circulating blood volume. Acute kidney injury is no one answered it? Okay, azotemia. What did we say that was?
The time keeps cutting out before I can even answer it.
Oh, I don't know why.
I can't do it fast enough.
Okay, I don't know what the deal is then. But azotemia is just that, messed up BUN and creatinine. That's all that is. Okay, post-renal kidney injury is what? This is going to be a mechanical obstruction in the outflow of urine. So generally you have some kind of blockage or stricture or something going on after the kidney. So like it could be in your ureters or somewhere in there even. So it could be a kidney stone. Okay, what phase comes after the initial phase of acute kidney injury? So this is that oliguric phase. So what's it mean when you're in the oliguric phase? What do you see? What do you see happening?
No urine output, like less urine output.
Yeah, so you're not putting out as much. So you may have like concentrated looking urine. Some of your electrolytes might be off. So what kinds of things would we do for someone in that phase?
Diuretics?
Maybe, and you may even give IV fluids too to try and like, pick up their output. So it just depends on, what's happening at the time. But yeah, so those would be some things you would do in this phase. An enlarged prostate could cause which type of acute kidney injury? So this would be post-renal because remember it's happening outside of the kidney, like afterwards. So remember we said the prostate's surrounding the urethra, so as it gets bigger, it cuts off the urine flow there. So that's a post-renal problem. What is an AV fistula? Okay, so it connects the artery to the vein. Name the type of dialysis in this picture. This is the peritoneal dialysis where you infuse fluid and it dwells inside your peritoneal cavity for a certain amount of time and then you drain it out. What's a common complication for a missed dialysis treatment? So you're going to have too much fluid on boards because typically they take all this off. So pulmonary edema is going to be your thing you're watching for. Urge incontinence is due to what? This is overactive bladder. Overflow incontinence is due to what? Yeah, so if you can't fully empty your bladder, that's usually what the problem is here. Which bacteria is most commonly the cause of a urinary tract infection? Believe it or not, it's E. coli. And typically you will see this because people don't know how to wipe correctly. And they'll like not wipe right and they'll get like stool in, the wrong place and it gets up there and causes a UTI. Okay, what's a lithotripsy? Okay, so they use these shock waves to break up your kidney stones, basically. And there's a couple different kinds of lithotripsy. There's one where they do it internally, and there's one where they do it externally. But basically, they both do the same thing. Okay, after extracorporeal shockwave lithotripsy, the nurse needs to do what? You need to strain the urine because you're hoping they're gonna pass these little pieces of the stone that was there, you know? So that way, at least you know that it's coming out and you could test it to see what kind of stone it is. Okay, which is a sign and symptom of an abdominal aortic aneurysm? Yeah, the back pain, and the picture was supposed to be your clue there. Which medication is used to help with intermittent claudication? Okay, so the correct answer is Pleatol. I was gonna say if anyone answered aspirin, it's not necessarily wrong, but it kind of is. So aspirin is a antiplatelet, which yes, you would probably put them on, but this Pleatol is more for intermittent claudication specifically. It helps with that pain and it just makes their circulation a teeny bit better. So that definitely is a good drug. Okay, decreased pedal pulses, cool legs, loss of hair on the legs, thick toenails, intermittent claudication. What do we? Yeah, so it's PAD, so peripheral artery disease. Which of the following symptoms would not be seen in arterial peripheral disease? So it would not be seen. So this, your varicose veins are more peripheral venous disease. Okay, a significant cause of venous thrombosis is what? Okay, so both 1 and 2 cause the venous thrombosis. So altered blood coagulation or vessel wall injury and stasis in blood. What does treatment for essential hypertension focus on? Okay, so yeah, with essential hypertension, that primary hypertension, one of the first things you would do is try to get people to modify some of the things that they can, like their diet and their exercise and that type of thing, before you just go ahead and put them on medications, right? Okay, what is essential hypertension? Good, so no known cause for this. Okay, what features separate, wait a minute, what features separate hypertensive urgency from emergency? What's the difference between the two? Yeah, the end organ damage. Okay, what is a healthy cholesterol level? so below 200. So the 150 goes with triglycerides. So if this said, what is a good triglyceride level, that's what you would pick for that. What electrolyte is important to check while on ACE inhibitors? The potassium, because your potassium can be elevated when you're on an ACE inhibitor. Okay, beta blockers. So they can do all three of these. So they can slow your heart rate, decrease your blood pressure, and you can use them with other meds. All right, good job, guys. Okay. All right. So that's all I was going to do with you. Did you guys have anything else you needed to ask me, or you feel a little bit better? Or
Yeah.
okay. All right. Well, I'm going to go ahead and get off here then. So thanks for coming. If you guys come up with a question or something, just ask me in an email and I'll see if I can get back to you. Okay.
Thanks.
All
Good.
right. Thanks a lot. Have a good evening.
You too.